Welcome to an animation of an alternate, superior hip approach, the Thru Broach Approach, developed by Dr. Peter Walker, Sydney, Australia. The Thru Broach technique is a unique, minimally invasive hip approach that allows early mobilization and minimal risk of dislocation. The patient is placed in the lateral decubitus position, slightly more away from the surgeon, to allow adduction of the leg for femoral preparation. A lateral incision is performed proximal to the greater trochanter, with the hip flexed. The gluteus maximus muscle is split in line with its fibers and a self-retainer inserted. The gluteus medius is then retracted anteriorly, and minimus is peeled off the capsule using a Cobb elevator. A curved retractor is then placed under the minimus anteriorly and around the femoral neck, and posteriorly under the external rotators. To aid in this posterior placement, the leg should be lifted up to relax the tension of the external rotators. The capsule is then on view and should be incised longitudinally, in line with the femoral neck, and then a T incision made. This can be repaired at the end of the case. Curved retractors are then placed under the capsule, both anteriorly and posteriorly, to expose the femoral neck. A pointed starting reamer is then used to open up the entry port in the piriform fossa, and then a hand reamer used to define the correct path in the canal. A cutter is then used to create a channel in the femoral neck in line with the version required. This is then cleaned up with a curette until cortical bone is exposed in the calcar region. The broaching is then performed in sequential sizes. The specially designed depth gauge on the lateral aspect of the broach can accurately define the depth of the broach and compare this to the preoperative plan. The top of the trochanter is a flat structure, and the depth gauge can be moved into any position and the pin pushed through the gluteus tendon until the bone is felt. The gauge position is clearly read off the numbers on the side of the broach. Once the final broach is in position, the femoral neck is cut at the level of the broach. 2 Chance pins are then drilled into the head at different angles, and the head removed by a levering maneuver. Curved retractors are then placed over the anterior acetabular edge and posterior laterally, and the self-retainer proximally moved deeper. The labrum and any osteophytes are removed. The broach handle is then reinserted and the aiming guide attached to the broach. The drill sleeves are inserted down to the bone, and a guide wire drilled into the lateral cortex. This is then overdrilled with a 5 mm drill. This small hole has minimal effect on the bone and is protected by the hip implant spanning it. It has been studied using finite analysis and has a wide margin of safety in terms of weakening the bone. This hole is required to allow direct reaming of the acetabulum. It allows accurate placement of the acetabulum and protects the femur whilst reaming. The drill and broach handle are removed along with the aiming device, leaving the guide wire in place. The C-arm outrigger device is then inserted over the guide wire and the reaming rod inserted. The soft tissues are protected by a cannula. The proximal cannula locks the rod into the end of the C-arm. The C-arm is then pulled by the assistant to create the working window between the gluteus muscles and the external rotators. The leg does not need to be held, it simply lies on its support in the desired position. No or very little retraction needs to be performed because the femur is being pulled in the direction of the capsule, allowing maximal space. The reamers are inserted and attached to the rod. If there is concern that the C-arm will hit on the lateral edge of the acetabulum, such as in a protrusio situation, then a spacer ring can be used. To remove the reamer, the assistant pulls on the C-arm, and the process is repeated to the correct size. Using this unique technique, exchange of reamers is simple and quick. The other unique advantage is that the reaming direction is determined by the C-arm and the hole in the broach. The leg can be easily moved into any position to determine the position of reaming. If the leg is horizontal, the inclination of the cup will be 90 degrees to the reaming rod. The version is simply a matter of flexing the hip. This can be visualized or simple angle measuring devices used, or even navigation if desired. The reaming rod is then swapped out for an impaction rod. The real acetabular cup is inserted using mushroom impaction attachment and the C-arm impactor used to impact the real cup in the correct position. The liner is then inserted, and a special trial neck inserted that allows trialing different head lengths without dislocation of the hip, and then the rod lengthened or shortened under direct vision. The hip is put through a range of motion and the appropriate head length chosen. The real stem is inserted. Again, there is a depth gauge on the stem inserter so that the stem can be impacted to the correct depth. The real head is inserted and the hip reduced. This is a truly unique approach, which is minimally invasive and, if required, is easily extendable to a normal posterior approach.